Every single year, millions of elderly patients walk into a hospital and walk out, or sometimes don't walk out, having been put under general anesthesia for procedures that in many cases simply didn't require it. That's not a small problem. That's a systemic failure in how we approach surgical care for one of the most vulnerable populations on this planet. And today, we're going to talk about it honestly, clinically, and with the level of seriousness it deserves. If you are over the age of 65, or if you have a parent, a grandparent, or a loved one in that age group who is facing a surgical or interventional procedure, this video may be one of the most important things you watch this year. Because the risks of general anesthesia in elderly patients are not theoretical. They are well documented, they are serious, and they are, in a growing number of cases, entirely avoidable. Let's start with what general anesthesia actually does to the body, because there is a widespread misconception that it simply makes you sleep and then you wake up and you're fine. That is not what happens, especially not in older adults. General anesthesia is a medically induced state of unconsciousness achieved through a combination of intravenous agents and inhaled gases. It involves the complete suppression of consciousness, pain perception, and protective airway reflexes. In order to maintain the airway, patients are typically intubated, meaning a tube is placed down the throat and into the trachea, connected to a mechanical ventilator that breathes for them. The entire cardiovascular system is under pharmacological stress. The brain is being chemically quieted, and the liver, kidneys, and lungs are all working to metabolize and clear those agents from the body. In a healthy 35-year-old, this is a manageable physiological insult. The body has reserve capacity. The organs are resilient. Recovery is rapid. In a 75-year-old, the picture changes dramatically. And the evidence behind this is not marginal. It is extensive, consistent, and growing. As we age, every major organ system undergoes measurable decline. Cardiac output decreases. The lungs lose elasticity, reducing functional reserve. The kidneys' filtration rate drops, sometimes by 40 to 50% compared to young adulthood. The liver's ability to metabolize drugs slows considerably. And critically, the brain, already navigating the neurological changes that come with normal aging, becomes far more susceptible to the toxic effects of anesthetic agents. This last point is where the conversation becomes especially urgent. There is a well-established phenomenon called postoperative cognitive dysfunction, commonly referred to as POCD. It is characterized by measurable declines in memory, attention, processing speed, and executive function that persists for weeks, months, or even permanently after general anesthesia. Studies published in journals including Anesthesiology, The Lancet, and JAMA Surgery have found that POCD occurs in somewhere between 25 and 40% of elderly patients following major surgery under general anesthesia. In patients over 80, that rate climbs even higher. But POCD is not the only concern. Postoperative delirium, a state of acute confusion, agitation, and disorientation that emerges in the hours and days following surgery, affects an estimated 30 to 60% of elderly surgical patients, depending on the procedure. It is not a minor inconvenience. Postoperative delirium is associated with increased mortality, longer hospital stays, higher rates of institutionalization, and accelerated progression to dementia. It is, in short, a catastrophic outcome dressed in the language of a temporary side effect. Then there is the cardiovascular burden. General anesthesia demands significant hemodynamic management. Blood pressure fluctuates, heart rate is manipulated, and in patients with pre-existing cardiac conditions, which describes the majority of elderly surgical candidates, the risk of intraoperative cardiac events rises substantially. Pulmonary complications, including postoperative pneumonia, atelectasis, and respiratory failure requiring prolonged ventilation, are also significantly more common in elderly patients who undergo general anesthesia compared to those managed with regional or local techniques. And yet, despite all of this documented evidence, general anesthesia remains the default in countless surgical settings, not because it is always necessary, but because it is familiar, it is standardized, and in many healthcare systems, the conversation about alternatives simply does not happen with the depth and transparency that patients deserve. That needs to change. And in many forward-thinking medical centers around the world, it already is. The field of anesthesiology has undergone a profound evolution over the past 2 decades. Techniques that were once considered adjuncts, supplements to general anesthesia, are now in the hands of skilled practitioners, complete alternatives for a wide range of procedures. These techniques fall broadly under the category of regional anesthesia and neuraxial anesthesia, and their application in elderly patients has been the subject of increasingly compelling clinical research. Regional anesthesia refers to techniques that numb a specific region of the body by targeting the nerves that serve that region. When done correctly, the patient remains conscious, comfortable, and breathing on their own. The brain is not chemically suppressed. The airway is not instrumented. The cardiovascular fluctuations associated with general anesthesia are largely avoided, and recovery in both the short and long term tends to be substantially smoother. Spinal anesthesia is one of the most well-established neuraxial techniques and is already widely used for hip fracture surgery, knee replacements, and lower abdominal procedures. A small amount of local anesthetic is injected into the cerebrospinal fluid in the lumbar spine, producing reliable, dense numbness below the level of injection. The patient is awake or lightly sedated, but feels nothing below the waist. There is no general anesthetic agent in the bloodstream. There is no ventilator. And the rate of postoperative cognitive dysfunction in patients managed with spinal anesthesia alone is dramatically lower than in those managed with general anesthesia. A landmark randomized controlled trial called the REGAIN trial, which specifically enrolled patients over 50 with hip fractures, compared spinal anesthesia to general anesthesia and found no significant difference in the primary outcome of mobility, while demonstrating that the spinal group had markedly lower rates of serious complications. Subsequent analyses have continued to build on this foundation, consistently showing that when spinal anesthesia is feasible, it should be the preferred technique in elderly patients. Epidural anesthesia works on a similar principle. Local anesthetic is delivered into the epidural space rather than the cerebrospinal fluid, allowing for continuous infusion and longer duration procedures. It has been used successfully for thoracic surgeries, major abdominal procedures, and even cardiac surgeries in combination with lighter general anesthesia, reducing the total anesthetic burden on the patient. Peripheral nerve blocks represent another powerful tool in this space. Using ultrasound guidance, a technology that has revolutionized regional anesthesia over the past 15 years, anesthesiologists can now visualize nerves in real time and deliver precise quantities of local anesthetic directly adjacent to the target nerve or nerve plexus. The result is a specific zone of numbness and pain control that can last anywhere from 6 to 72 hours, depending on the agent used, with essentially none of the systemic effects associated with general anesthesia. For shoulder surgeries, interscalene nerve blocks can provide complete anesthesia to the entire shoulder and upper arm. For hand and forearm procedures, axillary or infraclavicular blocks are highly effective. For knee surgery, femoral nerve blocks or adductor canal blocks, the latter being preferred for their reduced impact on quadriceps strength and thus earlier mobilization, have become standard of care in many institutions. For foot and ankle procedures, popliteal sciatic blocks combined with saphenous nerve blocks provide comprehensive coverage. What this means practically is that a significant proportion of orthopedic, urological, gynecological, and general surgical procedures can now be performed without the patient ever losing consciousness, without any inhalational anesthetic agent being administered, and without the cascade of systemic effects that general anesthesia sets in motion. For elderly patients specifically, this is not merely a matter of convenience. It is a matter of safety, cognition, and quality of life. There is also a class of techniques known as monitored anesthesia care, or MAC, which involves the administration of intravenous sedation agents in carefully titrated doses to provide anxiolysis and comfort during procedures performed under local or regional anesthesia. This is fundamentally different from general anesthesia. The patient breathes spontaneously. Protective airway reflexes are preserved. The depth of sedation is monitored continuously and adjusted to keep the patient comfortable without rendering them unconscious. Agents like dexmedetomidine, which has been shown to have a markedly lower incidence of delirium compared to benzodiazepines and propofol in elderly patients, have become increasingly important in MAC protocols designed specifically for older adults. The implications extend beyond the operating room. The concept of enhanced recovery after surgery, or ERAS, is a multimodal perioperative care pathway that incorporates regional anesthesia as a central component. ERAS protocols are specifically designed to minimize physiological stress, reduce opioid use, accelerate return of function, and shorten hospital stays. In elderly patients enrolled in ERAS programs, the data consistently show lower rates of complications, shorter length of stay, reduced readmission rates, and better patient-reported outcomes compared to conventional surgical management. This brings us to a conversation about opioids, because it is inseparable from the discussion of anesthesia choice in elderly patients. General anesthesia is commonly paired with significant intraoperative and postoperative opioid administration for pain control. In elderly patients, opioids carry a particularly heavy risk profile. They contribute to constipation, urinary retention, respiratory depression, sedation, falls, and delirium. When regional anesthesia is used as the primary technique, the need for systemic opioids is dramatically reduced, or in many cases eliminated entirely during the immediate postoperative period. This is not a secondary benefit. For an 80-year-old patient with moderate renal impairment and a history of falls, avoiding opioids in the postoperative period can be the difference between an uneventful recovery and a catastrophic complication. Now, it would be intellectually dishonest to present this topic without acknowledging its limitations and the clinical scenarios where general anesthesia remains the appropriate or even the only choice. There are procedures, complex intracranial surgeries, prolonged thoracic operations, emergency laparotomies, and others where regional techniques alone are simply insufficient, and where general anesthesia is not merely a convenience, but a clinical necessity. Additionally, not every patient is a candidate for every regional technique. Coagulopathy, infection at the injection site, patient refusal, anatomical limitations, and certain neurological conditions can preclude neuraxial or regional approaches. The point is not that general anesthesia is always avoidable. The point is that it is often used as the default when it should not be, and that the decision-making process is not always transparent, not always individualized, and not always reflective of the patient's values, their physiological vulnerabilities, or the current state of the evidence. And this is where patient advocacy becomes critically important. If you or a loved one is an elderly patient facing a procedure, the conversation with the surgical and anesthesia team should go well beyond signing a consent form the night before surgery. There are specific, legitimate questions that deserve specific, evidence-based answers. You should ask your anesthesiologist directly. Is general anesthesia the only option for this procedure, or can it be performed under regional anesthesia, spinal anesthesia, or sedation? If general anesthesia is being recommended, you should ask why, not confrontationally, but as a genuine inquiry into the clinical reasoning. You should ask what the anticipated risks of general anesthesia are given your specific medical history, cognitive baseline, and current medications. You should ask whether the institution uses an ERAS protocol for this type of surgery and whether your care plan incorporates it. You should ask about the plan for postoperative pain management and whether opioid-sparing techniques will be employed. And if you are at elevated risk for postoperative delirium, which many elderly patients are, you should ask what specific delirium prevention measures will be in place during and after your procedure. These are not unreasonable questions. They are the questions that a well-informed patient has every right to ask, and a competent anesthesia team should be fully prepared to answer them. There is also an important conversation to have about frailty assessment, because frailty is not simply a synonym for old age, and it dramatically changes the risk calculus around any anesthetic technique. Frailty refers to a state of decreased physiological reserve and increased vulnerability to stressors. It is operationalized through validated tools like the Clinical Frailty Scale, the Edmonton Frail Scale, and the Modified Frailty Index. Patients who are frail, regardless of their chronological age, face disproportionately higher risks from general anesthesia, longer recovery trajectories, and higher rates of functional decline following surgery. Many academic medical centers now perform formal frailty assessments as part of preoperative evaluation, and the results should directly inform the choice of anesthetic technique and the level of perioperative support provided. The broader landscape of minimally invasive procedural medicine is also evolving in ways that reduce the anesthetic burden on elderly patients from a different angle, not just by changing the anesthetic technique, but by changing the procedure itself. Transcatheter aortic valve replacement, known as TAVR, is perhaps the most dramatic example of this transformation. a procedure that once required open heart surgery under general anesthesia and cardiopulmonary bypass, with all the attendant risks that implies for an octogenarian, can now be performed through a catheter inserted into the femoral artery under light sedation with the patient awake and conversational throughout. Discharge occurs within 1 to 2 days. The clinical outcomes are equivalent or superior to surgical valve replacement in high-risk elderly patients, and the recovery is incomparably faster and gentler. Similar transformations are occurring across virtually every subspecialty of surgery and interventional medicine. Laparoscopic and robotic techniques have replaced open surgery for a wide range of abdominal and pelvic procedures, reducing incision size, blood loss, and recovery time. Interventional radiology has developed catheter-based approaches to treat conditions ranging from uterine fibroids to liver tumors to peripheral arterial disease, many of which can be performed under local anesthesia with light sedation rather than general anesthesia. Endoscopic techniques have replaced surgical approaches for a growing number of gastrointestinal and pulmonary conditions. The intersection of less invasive procedures with less invasive anesthetic techniques is producing outcomes for elderly patients that would have been considered extraordinary just 20 years ago. The role of the anesthesiologist in all of this is also worth examining explicitly, because there is a common misconception among patients that the anesthesiologist simply administers drugs and monitors machines during a case. The modern anesthesiologist, particularly one with subspecialty training in regional anesthesia or in geriatric anesthesia, is a perioperative physician who should be engaged in the patient's care from the preoperative assessment through to discharge planning. The preoperative anesthesia evaluation is not a formality. It is a comprehensive risk assessment that should identify opportunities to optimize the patient's condition before surgery, select the safest anesthetic technique given the individual's profile, and anticipate potential complications with a plan to prevent or manage them. If your institution has a dedicated anesthesia preoperative clinic, and many do, this visit should be taken seriously and used as an opportunity to have an in-depth conversation about all of the elements we have discussed today. If the institution does not have such a clinic, requesting a preoperative consultation with the anesthesiologist assigned to your case rather than meeting them for the first time in the holding area on the morning of surgery is entirely appropriate and can make a meaningful difference in the quality of the anesthetic plan. For family members of elderly patients who are not able to advocate for themselves, whether because of pre-existing cognitive impairment, language barriers, or simply the anxiety and disorientation of the perioperative environment, the role of a knowledgeable, engaged family advocate is invaluable. Someone who has reviewed the medical history, who understands the patient's baseline cognitive function, who knows what medications the patient is taking, and who is prepared to ask the questions outlined earlier, can directly influence the care decisions that are made. The evidence base supporting regional and minimally invasive anesthetic approaches in elderly patients continues to expand. Major anesthesiology societies, including the American Society of Anesthesiologists, the European Society of Anesthesiology and Intensive Care, and the American Geriatric Society, have all published guidelines and position statements emphasizing the importance of individualized anesthetic planning for elderly patients, the value of regional techniques in reducing delirium and cognitive dysfunction, and the need for systematic frailty assessment in the perioperative setting. These are not fringe positions. They are consensus recommendations from the foremost professional bodies in the field, and they should be driving clinical practice. The gap between what the evidence supports and what happens in routine clinical practice is a problem that exists in medicine broadly, and anesthesia is not immune to it. Changing that gap requires education at the provider level, structural changes within healthcare institutions, and, critically, informed patients and families who understand their options and are willing to ask for them. To summarize the core clinical message of everything we have discussed, general anesthesia is a powerful and sometimes essential tool, but it is not a neutral one. And for elderly patients, it carries a specific set of risks: cognitive, cardiovascular, pulmonary, and functional, that are not trivial and that are often understated in the preoperative discussion. A growing number of surgical and procedural interventions can be performed safely and effectively using spinal anesthesia, epidural anesthesia, peripheral nerve blocks, monitored anesthesia care with sedation, or combinations thereof. The outcomes data supporting these approaches in elderly patients are compelling and increasingly definitive. Frailty assessment should be a routine part of preoperative evaluation and should directly inform anesthetic decision-making. Enhanced recovery protocols that incorporate regional anesthesia and opioid-sparing strategies are associated with better outcomes in older adults. And patients, along with their families, have both the right and the responsibility to engage in an informed conversation about anesthetic options before any elective procedure. The conversation around general anesthesia and its alternatives in elderly patients is not about creating fear of a legitimate medical tool. It is about ensuring that the decision to use it is made deliberately, transparently, and with a full accounting of the alternatives, rather than by default, by habit, or by institutional inertia. Your age does not disqualify you from receiving the most thoughtful, individualized, and evidence-based anesthetic care available. And your questions, whatever they are, deserve real answers. If this video gave you a clearer picture of what those questions should be, or reinforced something you were already thinking about for yourself or someone you love, then it did exactly what it was meant to do. Share it with anyone who needs it. And if you have specific questions about your own situation, the most important person to bring them to is a qualified anesthesiologist who will take the time to address them with the seriousness they deserve.